So my name is Mika Newton. I'm the CEO of a company called XCures. XCures is a 6-year-old company, and we are focused on turning the chaos of medical records into clarity.
The chaos of medical records describes it pretty well, pretty much wherever you are in healthcare. Unpack that a little bit for me in terms of like what that actually means.
Sure. So if you think about the way medical records have been implemented all across the United States, and probably I would think across every geography that's out there, they've been implemented in a way that met the business processes and the clinical workflows of whatever institution they were installed in, whether that be a hospital or a clinic system, et cetera. And what that means is they're a lot like CRM systems, right? If you think of a Salesforce or anything like that, they were implemented in a custom fashion, have custom fields, right? Have different sections in it. And even more interestingly, most of the clinical relevance is captured in free text fields, so notes and discussions among physicians about what they're seeing and interacting with the patient on.
Yeah.
So in order to translate that, if you picture sending a person's entire history, and we sometimes see 10 to 20 years worth of patient history, from one place to another, what shows up is 30 different institutions' records, all written differently. And you can't read hundreds and thousands of pages worth of medical records for a clinical encounter. So how do you translate that into something that's actionable and appropriate for a specific encounter? Just get the right information out at the right time. That's the clarity that we're trying.
Yeah, absolutely. And I mean, we've got so many different, yes, of course, like everyone thinks about the EMR within a particular hospital as the source of truth in that particular location. And then you've got all the other kind of bits and pieces, all the other healthcare encounters that people have. And often within with the four walls of a hospital, the EMR doesn't become the source of truth anyway. So like there's so many different points of information. To be able to have a single source sounds great, but the practicalities of actually doing that, like what does that actually look like for you?
Yeah, so you're hitting on capability that is just coming into its own, at least here in the United States, and it's around interoperability. So if we think about kind of two important concepts, health information exchange, which really started, I think, from the experience of Hurricane Katrina here in the United States, and the realization that when people are dislocated, you really wanted to know what they were being treated for and the medications they were on. And a government effort around meaningful use and EMR adoption, right, that essentially paid for now the development of EMR systems and now through health information exchange, the exchange of data. So that was the initial piece. And now we're talking about something called QHIN, or Qualified Health Information Networks, which are just coming to their own. And they really originate in the 2016 21st Century Cures Act that was signed here, and a common framework agreement that was defined called TEFCA, T-E-F-C-A. So as that comes into being now, we're starting to see there's specific entities that are charged with exchanging data. So this has been going on for 20 years, and really within, I would say, the last 2 years, it actually started working, right? And I don't think people have quite realized that this sea change is taking place. And so suddenly now you're starting to see the exchange of data, but it's happening at a network level. So think about the internet, right? We don't think about how the data shows up on your application or in your browser, but it doesn't come in one straight line. It comes through a lot of different queries in different places. So all of that architecture is in place finally. And so this point we're at suddenly enables basically a whole new age of digital health, innovation, right? Better patient care, better understanding of patients' histories, better quality insight. I mean, it's the entire healthcare industry. And so I think of this, it's like we're at the beginning of the internet.
Yeah, and so for XCures then, is that like a view over the top of everything that's come together? Are you cleaning it up? Like, what is it that, say, a hospital might see, or a health system, or a payer, or like what do they see when they do with their XCures?
Yeah, let me give you a very specific example that was given to us. So I'll talk about medical device companies, right? And in particular, actually, let's focus on advanced diagnostics, actually, is a better one. So if you're an advanced diagnostics laboratory and you're running something like a minimum residual disease test, let's say, or some sort of NGS assay, when you run that test, the data that you receive about your patient in the ordering function actually affects the interpretation of the test itself. And so they have a pretty complex TRF, or test request form, that gets filled in by the patient and the physician. Now, when the company receives the order, they might receive it through Epic or Cerner or a large EMR system. They might receive it through a company portal.
Yeah.
They might show up on the fax machine written in my hand. And so being able to now say that regardless of where the data comes from, right, which system it comes on, I'm going to drop down to the core exchange level extract the data myself and turn it into a standard form is a huge leap in efficiency and ability to get the supporting evidence. Because not only are you getting the data, so think of a form, there's some information that someone wrote in, but you don't have the underlying data, whereas in this case now you can actually get the supporting documentation and all that. So that lets you run better tests faster, more efficiently, with more accuracy, less callback to the physician, less callback to the patient. And you can take all that data now that you've acquired it and put it into your business process and operations. And it has lots of flow down secondary uses as well.
Yeah.
But that initial treatment of the patient use case is finally possible. That's never existed before.
I'm just thinking back to when you said, because the XQ has been around for 6 years, I think you mentioned, and you also said that probably only in the last 2 years we've seen like some real tangible change when it comes to, the data exchange capability. Like, what's kind of changed in that 6 year and 2 year kind of time frame that's kind of triggered those moments, or has it just been has it slowly crept up on us over time?
So, Peter, I'd love to say that we got to where we were at some master strategic stroke of genius.
Yeah.
Well, I'll say that anyway. But in reality, when we started the company 6 years ago, we were actually focused on a very different problem. The problem we were focused on was clinical decision support for advanced metastatic cancer patients. So basically, you have cancer, nobody knows what to do, and you need to pick some chemotherapy or off-label therapy or a clinical trial, and it's a very difficult situation to be in. The comparator, right, of what you would do in the human world instead of using clinical decision support would be you would assemble a tumor board. So you'd get a whole bunch of physicians together, your leading academic institution, say, we don't know what to do. Give us some advice. What are the top 5 things you would recommend for me based on what you know about me? And so we developed software as a medical device and actually started the process of developing a fully validated clinical decision support system below that. For lots of reasons, right? You can actually build better clinical decision support and make better decisions than you can. There's some regulatory hurdles to something that might, for instance, provide off-label recommendations, et cetera. And so as we were going down that process, we realized, you know what, we can make really great decisions for patients, or at least decisions that are good enough to improve the interaction between the physician and patient. But the problem we had over and over again is we couldn't get the data that we needed in order to run the algorithm in the first place.
Right.
And so how do you get the data? And it has to be fast. Like if someone's going to go see their oncologist tomorrow, you can't say, oh, well, I'll give you my recommendation in about 30 days, right, once I process. It just doesn't, it's useless, right? Absolutely useless. So we started looking for sources of real-time data. And so we found HIE and QHIN, right, this health information and qualified health information network systems early on. But if we go back 3 years, they didn't really work. They responded like 30% of the time. And so what really changed then, you asked about the last 2 years, is that went from 30% to 85 to 90% or even better now in the United States. And I think as different countries start to look at healthcare interoperability and put in place both the mandates from a regulatory perspective, and in the U.S. we have both incentives and now we have penalties for payment, it's going to make a huge difference. And there's so much we can do with this.
Interesting. And so for XCures, we're here at Health and everyone's sharing updates and excited about the future. What can we look forward to seeing from XCures and when looking ahead?
Yeah, thank you. We just launched basically the next gen of our platform. So the first generation of XCure's semantic interoperability layer sat on top of data exchange and basically allowed you to do extraction from the structured data. It would present the clinician notes to you and allow you to look for essentially keywords or terms. So if you think of natural language processing as a technology, we would basically term index the entire medical record. Anything that was embedded media, so embedded PDF, TIFF, CDF, JPEG, right? We would do OCR, scanning NLP. So all of that stuff is scanned in the process. What's been moving really quickly, and I think we talk about this all the time, is AI and large language models. So now we've taken that entire infrastructure and in addition to the NLP, really integrated a large language model infrastructure and AI infrastructure across all of it. And what does that give you? That means when I look at a patient's medical records, and I have a demo patient I use all the time, this lady has 650 medical records, I can search by, the actual terms that are in it. I can search by the NPI number and the specialty, which location it came from. But the new capability is a search bar where I can say something like, show me the gene alteration reports, and it will find the documents that talk about, that's a concept, an inference, and it's a clinical concept. But without this LLM AI, you can't search it. That gene alteration is not a specific term that will take you to the rate data in that. So now you're able to do that.
Yeah.
The other thing we can do is look inside of notes and start thinking about, right, and actually we're doing this with incredible sensitivity and specificity now, surfacing terms or concepts that only appear in the notes. So one of them in cancer is progression, right? So progression is a bunch of different data points across the medical history that come together that someone uses as a human being to say, oh, well, this patient is clearly progressing, but it's not one single thing.
Right.
And so now these models allow us to do that. One other example there, ejection fraction. So in cardiovascular disease, ejection fractions are a particularly important topic. There is no structured ejection fraction field anywhere in the record. And you can't just look for ejection fraction, because it's actually mentioned all the time.
Yeah.
But the clinically relevant measure of ejection fraction is in the cardiologist's notes at a particular... So all of that infrastructure that is going to make this really quick, because frankly, healthcare doesn't need more databases to search, more time spent on an application. It needs the information. You and I want this. When we go see our physician, we want them to have the information to provide the highest quality and content of care to us, like right now.
Yeah.
At their fingertips, and we don't want them spending all their time coding, charting, and reading the record.
Yeah.